some of the most important relationships you have in healthcare are obviously with your communities and with your patients, with your care teams, nurses, and allied health professionals, but also with your doctors. But we've become so good at those transactions of healthcare, that we've kind of lost the relationship. We're all kind of in the same bus together. And I think when we start to recognize that we care for each other and when we start to love each other, I think we can start to create something much more beautiful than we have today.
Let's talk some about, I have like a chicken or egg sort of question. Which came first? This is shifting a bit of our conversation. Which came first? People are traumatized, and then healthcare is not managing that, or healthcare is not managing us well, and so we become traumatized. Does that make sense? And it may be some of both. I'm curious from just a curiosity. I want to be a learner, point of view, but there's a practical application to that. And that's so much of your work is actually how do we come alongside people? And so, to restate that, people are traumatized, and so healthcare is not meeting that need, or was healthcare not meeting the need, and so it traumatizes us? Like what? And here in these spaces, we use trauma and mental health challenges like interchangeably, and so not really, small definitions around them, but broad definitions.
That's a wonderful question, and if I can stay on the faith side a little bit,
Please.
Because it's a big part of who I am. And
Please.
So if you look through the New Testament, and in the King James Version or English Standard Version or NASB or NIV, whatever you choose, anytime you see the word heal, whether it's Jesus healing or wherever the word heal was used in any of the epistles, the Greek word, assuming that the origin of that book was Greek, with some exception, that's generally how the New Testament was, the word is sozo and sozo. I don't know the correct pronunciation, but I'm going to tell you what it means. And it means something so much broader than our narrow definition of heal. And here we go. It means to heal, to make whole, to rescue, but it also means to save, and also means to deliver. And people of that world were and actually the Old English and Middle English used a word called halen, Haelan. So on up into the Middle Ages, that word halen meant the same thing. It had to save and had to deliver as well. And so in the ancient world, there was this idea that health was something so much more than just physical health. Like I said, it meant like refuge. It meant sanctuary. It meant a deliverance from something. And I think the problem that we are discovering, and I can step away from the faith-based world now and go into the secular world. Vivek Murthy was the Surgeon General under much of the Biden administration. And in 2023, and I can't help but think it must have been almost in response to the growing division that the pandemic caused in our communities, he rolls out this document called the Epidemic of Loneliness. And if you have a chance to look at it, maybe even link it in this podcast, he lays out this highly compelling, data-driven expose of how divided and lonely and isolated we are becoming in our modern world. And he quantifies it 80s, 90s, pre-pandemic, and then the immediate post-pandemic. This is 2023. This has been happening for a while, but it was rapidly accelerated because of public health policies and otherwise during the pandemic. And he goes in there, goes back to the faith-based part. He goes in there and he says 80% of physical ailments is can be derived from loneliness, can be sourced back to loneliness. And if that's true, and again, I think the data is pretty compelling. And if loneliness and wholeness and community and salvation and rescue, if all of that is part of health, and we're here looking at just biomedical science, we are missing so much of the definition of health. And so now back to your question, like which one came first? I think we have to look at what health really is. Health is our relationships, health is our diets, health is our biomedical health. And again, let me dive deep on that real quick, because if I don't push this a little bit, I think I could be misheard. America, Norway, Sweden, Netherlands, England, Europe, many parts of Asia, Singapore, Japan, we are pushing biomedical science to beautiful levels. There is an amazing amount of biomedical research that has saved hundreds of thousands, millions of lives around the world and has enhanced the lives of many, many, many people. I do see in our country, we have gutted the NIH and we have gone, I'll just speak clearly, we are going backwards on biomedical science in ways that is going to hurt us for many, many years. So, biomedical science, good. Biomedical science, great, and we need to continue on that pathway. While we're going down that pathway, we cannot forget who we are as human beings, the importance of our dinner tables, the importance of our relationships, the impact of our ancestry on us. And again, back to my faith and journey, which is like we cannot have health and wholeness without looking at that salvation, without that deliverance, without that sanctuary, without that rescue. And we need to kind of put that all back together. And that really is the biblical model, is piecing that all back together. And again, to me, that would be a pastor working with a doctor. And that might be creepy to some people. Like, I want that to be separate. Well, keep it separate, but recognize that you're not really whole, and working with your imam or working with whatever your faith leader is. Like recognizing that you have to look at the human being collectively, and you can do that in a separate but dyad relationship, I believe, and start to serve communities in different capacities. So those are things that I'm exploring currently, and I hope that answers the question. And I kind of danced around it, but maybe to summarize the answer to your question, if we separate biomedical science from the broader human experience and we only put money into one, we will not be building healthier communities. And on the flip side, and I think we're seeing this a little bit, if we just spend all the money on the social, cultural issues and we neglect the biomedical, we will also see a similar collapse in potential health for ourselves and our communities.
Absolutely, because we are not just our physical selves, we are our emotional selves, we are our spiritual selves. We have many parts. And I've always found it fascinating and sad in some ways that, you know, if I break an arm, like that's obvious. You can see it from the outside usually. You can take an x-ray, you can see it. But and it's very obvious. But if I have like a broken spirit because I'm grieving something,
Mm-hmm.
then you can't see it like a broken arm, and nor can you heal it like by putting a cast on it. It's going to take time, it's going to take relationship, it's going to take perhaps some content, and from our faith point of view, it's going to take some dependence upon God and his
Mm-hmm.
ability to heal, and Jesus and his presence in our lives. So I think that what's so hard is that the biomedical pieces are obvious. It's obvious when something's wrong with us because we've got symptoms or we're bleeding or that something's broken, right? What's so hard is when we can't identify it, when we can't see it. We just see the results of it. We see the behaviors around mental health challenges and trauma. And I think so many of us, we know what to put a physical Band-Aid on. If
Yeah.
a child comes in and they've scraped their knee, we're like, oh, let's clean it up. Neosporin Band-Aid. We're good, right? Keep it on there. It'll heal. We don't know how to help each other heal in emotional ways. I think we're growing in it. I think we're all learning every day, myself included. But I think
Hmm.
the more that we can kind of push into these areas that are more unseen and less obvious, then we can we can actually become more like you were trying to talk about, like this dyad of the physical and the emotional and the spiritual. So yes to all of that. And so what would you say to like a healthcare network or a hospital or a clinic about ways? I mean, I'm very biased, of course, because
Hmm.
I see the ways that understanding trauma, its impact has affected my life, my family, my work, my clients, organizations we work with. Like I have seen all of that, but you also know firsthand those impacts on healthcare systems in a way that I don't, and many of our listeners don't. So, can you talk some about the impact of having the staff at the clinic, healthcare facility, whatever, the impact of the staff understanding trauma and knowing how to apply trauma informed practices, the impact that that can have on themselves, on patients, on retaining staff, like equipping folks so that they can stay and maybe not leave that job, and the cost, the financial cost of all of that. Like if you could talk to some of that. It was like 14 questions in one.
No, and I think because it hits here, right? And Meredith, you and I have been on this journey for a couple years together. And of course, you and I saw the impact of trauma informed care in a immediate post pandemic ecosystem when people didn't have language to describe what they were feeling. But to your long question, if I can give a medium story, I want to. I'm trying to think if I want to go here for you and your listeners, but um, okay, zoom way out with me, and like every listener, just go on this journey with me. So zoom out. So you're a healthcare executive. You came out of finance. You're a CPA, and you could drive a private equity for profit hospital system, and it'd be great. But now, imagine if one day you found yourself in rural communities, and all of a sudden everything you learned in the city just didn't quite work. And I'm going back to your question here, but imagine if all of a sudden, over the course of meeting some people along the way on a journey, you started to realize that maybe I'm trying to think how to link this. Okay, so the problem statement is I mentioned it earlier, like 20% of the United States GDP is being spent on healthcare, and we're getting far worse outcomes than the other OECD countries. Those are the countries like they're all equally wealthy on a per capita basis to the United States. And we're getting a fraction of the outcomes that they're getting. And so if you were in charge of spending that money, you'd be like, well, you know what, I'm not getting what I'm paying for here. And so you'd start asking questions around why is this happening? And we've been asking that question for about 30 to 40 years. And what it's telling us is that the work that we're doing is delivering healthcare to people, like we're doing surgeries and we're doing prescribing pharmaceuticals and we're diagnosing people with amazing imaging and we're saving lives with great emergency and trauma care. But we've become so good at those transactions of healthcare, that we've kind of lost the relationship. And so now let's get back to your question here on this one. And again, you don't have to go with Judson on that journey, but just know that that's where I'm asking myself those questions. And so if relationship is so important, and Vivek Murphy is saying the same thing, Surgeon General in 2023, and if the biblical model of your own heritage background and you work for faith-based nonprofits, if you're kind of like connecting those dots with me. So let's talk about the relationships of healthcare. Some of the most important relationships you have in healthcare are obviously with your communities and with your patients, with your care teams, nurses, and allied health professionals, but also with your doctors. Now, let's just take a moment to talk about doctors. They're not more important than the nurses and the care teams or the patients, but let's just talk about the doctors for a little bit, because that's where I have a little bit of a story. I called somebody in 2021 that had built a waiting list of primary care in like Western Kansas. And Meredith, you know this person I'm talking about. And Western Kansas is a beautiful place with beautiful people, and I've driven through it one time. I made it through pretty quick. But I'm just going to be honest, and I see you, Western Kansas. It is not as beautiful as Northern California. I'm just going to call it. I'm just going to just tell you, it's beautiful places to live, and I would love to live out there. It's not redwood trees and rolling hills of grapes with four seasons without any snow. And so what I was finding is, why I asked the question, why can someone recruit in Western Kansas create waiting lists of physicians, but I'm struggling up here in the borders of redwood trees and grapes and ocean with four beautiful seasons a year, and I can't recruit. And I started to process this as the leader of this delivery system. Like, maybe I'm the problem. Like, what could I do differently to create a different future? And so this is a very powerful and maybe dangerous realization, because one thing is, you're not that important. It's not really about you, both good and bad. But the second time is this powerful and empowering motive of, if I can do something, what are the things that I can do? And for me, that launched me on a realization journey that there is so much that we can do. And in that journey, I realized, and let's focus on the physician side, I realized that there are many physicians that are outside the United States, elite American physicians, that are choosing to work outside the United States in environments that are much more challenging clinically and maybe even personally than what I could offer in the United States. And yet people are choosing to do that. And so I said, well, why is that happening? And what could I do to align with those values so that maybe my community could be interesting to those folks as well? And of course, you have to work through a few things, and I won't go into it too much because you have to know healthcare's idiosyncrasies really well. But in healthcare, there's this really steep hierarchy with like specialists and subspecialists on the top and like primary care doctors down here. And there's like this whole hierarchy, and it's like it's created this interesting issue. But again, if the relationships are the most important part, then how do we invest into relational medicine? And you find out that that's in primary care. So for those that aren't in healthcare, that's like family medicine specialties, that's internal medicine specialties, that's sometimes people call that OB and GYN work. Pediatrics sometimes fit into that category. It's really like where you first bring people into the healthcare navigation world. And if you look across America, that is such a crisis. We are beyond crisis in that space right now. And my corner of that world was rural America. And I started to ask doctors, like, why would you go to countries overseas like Mauritania or Chad or southern Mexico or Guatemala, all beautiful places. And I think you should be there. But what would it take for you to also be in my community and potentially both communities at different times of the year? And so this is where I was going to go with this, Meredith. The response I got collectively was, my values in healthcare don't align with your values. And I'm in healthcare for a different reason than you are. And until you can align those values, and no one was being hubris saying you have to change to me. They were just saying, I don't want to transactionalize the work that I do. I want to be in the work of relationships and healing people. And if your community and your delivery system and your healthcare is that, then maybe I can have a conversation. I'd be interested. What I learned is that is a very winsome way to talk about healthcare, and that can be really uncomfortable for people that have never experienced fragility in healthcare and only understand the corporatization of medicine as something that you have to drive forward, cut costs, pay more, create margins, and ultimately that becomes extractive. At some point in time, you're extracting resources. Um, and I think where we've lost quite a bit in healthcare over the last 20, 30 years from my lens. And again, I say this humbly. I'd love to hear back from listeners and if I'm seeing this wrong. But I think that we used to have more community connection, and we weren't just thinking short term profits and margin creation, and we were thinking 20, 30 years down the road. And that allowed us to be, I'll use the word that's the opposite of extractive, that allows us to be generative. And what if we could collectively generate health together? What if we could actually, would we have more doctors? Would we have more people, clinicians wanting to be a part of that? Would we have not scarcity, but maybe abundance? And as I start to talk this way, I can tell you this is really uncomfortable language to people from my background. People that are CFO types like myself, people that used to be public accountants, people that know how to build beautiful spreadsheets and drive margin. When you start talking about abundance, they start to get really uncomfortable, that potentially we've kind of lost, that Judson's lost his mind. But I can't unsee this stuff, Meredith, because one, I saw how physicians and clinicians responded to value alignment. I also saw how the economic models of American healthcare work when you can actually reorient the economic systems around values and outcomes. And I know this because, um, and before I left hospital executive leadership, as I started to change the way that I saw healthcare and start to see the results of value alignment with mission driven physicians, I started to see my economic results climb. And I saw my quality climb as well, because as patients have a better experience with their clinical experience, they also start to feel that the outcomes are better as well. And you start to see this virtuous cycle that goes the other way. Um, I'm working right now through a theory of change. Like, how would you go about influencing other people in American healthcare along this? And so, yeah, I'd love to get your perspective, Meredith, but this is what I'm working on currently is that theory of change and how do we create movements around this way of thinking.
Well, I think so much of what you talked about is the importance of relationship over transaction,
Hmm.
right? And
Correct.
relationship is, there are many elements to our relationships and it depends on the relationship, but for someone who's providing, central to our person, like medical care, we, I mean, trust is basic. And we want to be able to have what we talked about from the very beginning, that, this felt safety, this emotional safety where we can give our full history, where we can share in the clinic space, like what we experienced over the last month while we were taking that med, and all of that openness and vulnerability and honesty is a part of that medical relationship, or we hope that it is. But when it becomes more transactional, there's really less sharing of information, there's less safety felt. So there's a definite correlation there between how we are doing in our mental health space and the relationship that I'm sitting in front of, depending on who
Yeah.
that is. And so, what would you say is is the relationship, that piece that is so important towards mental health, like the mental health pieces of the relationship in a clinic setting, in a hospital setting.
Yeah. If the question is, like, how do we improve that relationship in the primary care setting?
Yes, that's great. Yes.
Like, I think there's two answers, and I think if you surveyed 90% of my peers would say technology is going to change the way we deliver primary care, and it's creating access to behavioral health specialists, and um, that's true, and that is beautiful, and thank goodness. And I could give you stories, Meredith, of how technology has enhanced and saved a life of someone in an acute behavioral health crisis. I can give you that story and remove them from, I'll go to a challenging example in our emergency rooms across the country. Like, we're now using telepsychiatry, that is allowing us to reduce the amount of restraints that we're having to provide and give people quicker access to medications that only psychiatrists can give, and really and get them into the sites of care that they need to be in. It's beautiful, but it's not getting us to a better place that we need to be. And I think what really needs to happen is we need to give, all right, who owns healthcare, right? And I think that's the first question we understand. And and I think we'll all say that the patient has the agency to lead healthcare, and that the physician is kind of the point in that delivery system. But what is really happening is, as we are transactionalizing healthcare and we are delivering healthcare, the system around that, and I want to use the word system importantly, because we are not talking about a bad person out there trying to do bad things to hurt people. That's not what's happening. What is happening, and it's happened through the course of human history, is we build systems that get so big that the systems start to get the need to reinforce themselves and to sustain themselves. And they're getting, as Deming said, Deming is a famous systems thinker, he said systems get exactly the output that they are designed to get. And right now our systems are designed to create, designed to deliver healthcare. I jump back now to your question. Is that really why a physician goes into medicine for 25 to 30 years of their life, to come out and to join a system and to write prescriptions and to send people to diagnostics and to send them to specialists and to move them down the points of care? Or did people really go into medicine to connect with human beings, to listen to what their issues were, to sit down with them and find ways to use their biomedical wisdom as well as their social services wisdom and connect those dots to create something better for that person and for their family? And so I think that is totally at odds with what is happening in American healthcare today. And yes, we can use technology, and yes, it is going to solve significant problems, but I'm already starting to see people use it to further transactionalize healthcare. And until we can get back to the relationships of healthcare, which honestly, secret, is less expensive than all the diagnostic stuff we're doing and pharmaceuticals that we're doing. If we're really serious about bending the cost curve, which is what we use the term in healthcare, to bend the cost curve, and that's the total cost of healthcare, which is going like this in America. If we really want to flatten it out and bend it, we have to get back to relationships in healthcare. And so yes, I think right now, honestly, family medicine, internal medicine, is going to have to reorient themselves away from I have to be careful how I say this. I don't really have to be careful, but I'm choosing to be careful. So now I'll be less careful. And that is, we have to take our physicians off of hamster wheels and let them be in the moment with their patients. And I say physicians over and over. Nurse practitioners, PAs, I see you as well. You're doing great work. Okay. So this care team has to exist in the space of connecting with the human being. And that's why I brought up sozo and the word halen in Old English, because We have to rebuild these connections. And technology can help, but it's only going to be as good as the human being that is there trying to connect with other human beings. I will also add this as well, and I'm stealing from a very impressive healthcare system in Anchorage, Alaska, and it's called South Central Foundation, and they have branded their delivery system called the NUCA system of care. That's NUKA. And the leader of that, or the architect of that, is a gentleman named Dr. Douglas Eby. And he is one third physician, but if you meet him, he's one third anthropologist and one third sociologist. And you'll realize he taught me three secrets to fixing behavioral health and physical health and trauma in the primary care setting. And that was this. It's like, Judson, never forget the anthropology of medicine. And that is that human beings are a culmination of values and ancestry and beautiful traditions that are different from person to person. And I, as a physician, am blessed with the opportunity to sit there in that moment with them and to co-produce and to co-create with them a solution to their health issues. Secondly, I can design my workplace in a way that fixes that hierarchy of medicine, that doesn't put some physicians over other physicians, and we need those subspecialists. I'm not saying we don't, Meredith. We need them, and they're doing great work. But we need to somehow collapse the hierarchy into, again, humility, where we're letting practitioners, nurse practitioners, PAs, doctors connect with patients and provide them with the resources in a flat structure so they can consult with those subspecialists, have case managers with them, have pharmacists with them, so they can utilize those resources well. But thirdly is probably the most important secret of addressing this primary care behavioral health crisis. And that is, each patient is not really just a patient in the traditional sense. They're really a customer, and they're also an owner. They own their health. And we have to run alongside them in a way that understands their culture, is humble enough to recognize that our values are not their own, and that ultimately they exist as part of a community, and that we are blessed to have the opportunity to be here. And if we were to apply this, and I should say for them, they have won 3 Baldrige Awards, which is like the Grammy or the Oscar of healthcare in the last 24 years. So if they were a movie star, they'd be bigger than Tom Cruise. But they are seen as and their cost of care, by the way, is they make more money because they have reduced the cost of care significantly because of this model that I'm sharing with you. But if you look at what's happening in the lower 48 states, they are largely ignored because they say, oh, that's an Alaska population, that's different. What they're doing wouldn't work in Tulsa. I'm making that up. Well, the reality is those universal truths that I just shared are truths from antiquity. And we have to figure out how to recognize that the system is producing what the system is going to produce, but we have, as individuals, have personal responsibilities to our neighbors to connect, to minister to their needs, to meet their needs, to serve them. And if we all, as collectively, as a nation, started to do that, we would see our behavioral health crisis collapse. Is my personal belief.
Okay, so that was beautifully stated. And what I'm hearing you say, or what I think I'm hearing you say, is yes to behavioral health, yes to psychiatry, yes to therapy. All of those things are essential and needed and need to grow, and people need to, access those services. Yes, 100%. But also, there is a mental health component to every single interaction that it takes place in a healthcare setting. From providers to nurses to, x-ray techs to the person sitting at the front desk. There is a deep, understanding that we as human beings have about our own needs and our own ownership of our health and our mental health within that. And so, am I correct? Am I summarizing a little bit?
I just don't want to. I struggle a bit with the personal ownership when it comes to behavioral health because I don't want someone to walk away feeling like they are a problem or that. Um,
Absolutely.
but what I do want to say is that you and I and people listening have a responsibility to our neighbor, and we can't necessarily address all of the acute behavioral health issues of our neighbor, but we can listen, we can connect them to resources, we can open doors, we can be present, we can share space, we can create community, um, we can create alternatives to our technologically driven dopamine addictions that we're all exposed to at this point in time. And as you said earlier, we can get outdoors. But I do want to just say I am not clinical. Like my job is actually to serve the clinicians to make sure that they have the resources they need to make sure that they are seen and that they are heard. But I don't want to step as far, Meredith, into the space of the clinician because I think they would tell me, Judson, the behavioral health crisis is very diagnosable. There are very specific issues happening there. Please don't Pollyanna away the disease profiles that we're seeing in this space. And so I apologize if anything I've said has come across that way. But I do want to say, from a personal manifest, I want to take care of you, Meredith. I want to take care of the physicians in my clinics. I want to listen in a way that augments their ability to manage the behavioral health wave that we're seeing today. And again, the behavioral health wave is real. The physical health wave is real, especially in chronic disease. And the substance use wave is real as well. And I would say if anyone listening to this is struggling with any of those, I see you, I love you, no issues with me, happy to talk about it. We're all struggling with that, by the way. You're not alone. We're all struggling in some capacity with one of those things. Um, what I'm trying to get out there broadly is seek the biomedical support that you need. Go get it, but also see that we have a responsibility for the person next to us. And I'm saying there is power in that service, and that collectively we can build stronger communities that are more supportive. So that whether people are going through acute behavioral health crisis or chronic behavioral health crisis, this is going to take multiple generations. And again, I think many will disagree with me and may not have the same faith journey that I have. I actually think we need a relationship with Jesus Christ through this as well to really find the healing. But I recognize some people might be hurt by the history around that language as well. And so I see that as well, and I honor that as well. But just know that that's kind of where I'm at as well. And I think that's important as I've studied this stuff further, is that there's a deep knowledge in our language that understands that health is something more than biomedical science, and that there are models that work that we should be looking at.
Absolutely. I love how our conversation today has really addressed, you know, folks that are in your sphere, healthcare professionals, healthcare executives, but also those, you know, providing the care from every part of the clinic visit or hospital visit, and also folks delivering behavioral health and, you know, psychological services. But also you've addressed just anyone really, because we are all facing different challenges. As we say here, we're all on the trail. We all have our different challenges that we're facing in mental health space. And you've reminded us of the importance of community. So in this conversation, whether you're a healthcare executive or someone's neighbor, we all can step in and join together to form communities in ways that people and each other, we can feel seen and known and heard and loved. Certainly the role of faith is absolutely vital in all of that. And man, I just really appreciate all the things that you have brought to light for us today. And so I have a closing question, and we we like to close with the question, where are you seeing beauty in the world today? But I would like to ask specifically, because I know for you that dinner time is a very specific and lovely and
Mm.
beautiful time for you and your family. So, where are you seeing beauty in your time at dinner with your family in this season?
Meredith, I'm gonna reach up here and I'm gonna grab something on the top of my computer and I'm gonna show it to you. And I'm gonna see if we get in focus. This is a tiny little cut pine branch. Okay, and it was cut with a pocket knife that belongs to my 10-year-old. And yesterday he brought this in to me and said, "Daddy, I want you to have this because it smells great. It smells like the outdoors. It smells like pine." And he was just so proud that how he got the cuts on this. The bias on that is perfect. Um, I have had the opportunity that I think very few have in this season of their life, and that is to invest deeply into my family. And um, a lot of us have different experiences with family, and I see that, and um, I can just speak for myself. Executive leadership is really challenging on families. I know being a clinician is challenging on families. I know being on the receiving end of a challenged family environment can be really challenging as well. Potentially having identity issues with family, all kinds of issues. But I can say if you have the time to invest in those that love you or that you love, that is eternal and that is restorative and that is generative and that is healing. And I have really enjoyed and found significant beauty um, in things like a 3/4 inch pine branch that smells like pine sitting as a gift from my son on my computer to make sure I have the outdoors in my computer. So, um, yeah, the small things in life carry a lot more weight than they have in the past, and I think it's been a real gift.
My goodness, that is a wonderful gift. And I just love that you've shared so much of your heart, your faith, your professional life, your family life. You've shared so much with us today, and
Mm.
I know it's a blessing to me already, and it's going to be such a blessing to our audience. And man, we're just so grateful to have you and for you to take such generous time with us today.
Thank you so much. And just anyone out there, whether you're in the space of trauma informed care or you've benefited from the receiving end of trauma informed care, I see both of you. I see all of you. We're all kind of in the same bus together. And I think when we start to recognize that we care for each other and when we start to love each other, I think, and then we provide the beautiful science that we have at our disposal. I think we can start to create something much more beautiful than we have today. So thank you, Meredith, for the chance to connect with you and your team and your audience. And thank you for what James Trail is doing in this space. I wish you guys all the best.
Thank you so much, Judson. And to our listeners, we will see you on the trail.